And I'd say in my clinical experience, this is one of the systems that's probably the most common missing piece for patients, where they've been doing a lot of really beneficial things. But if this is missed, it's always going to be a barrier towards your recovery in terms of not assessing that and not treating that specifically is always going to be something that's going to limit the ability of some of the other things you're already working on that should be valuable and maybe are valuable, but they might have limiting returns just based on this ability.
There is always hope, and you are not alone.
Welcome to Hope Survives, a podcast from the Hope Survives nonprofit supporting individuals and families navigating life with brain injury. I'm your host, Cristabelle Braden. After my own experience with traumatic brain injury, including multiple re-injuries, I've learned how isolating this road can feel and how hard it can be to find a way forward. No one should have to walk it alone. On this show, we explore the realities of life with brain injury through encouragement, thoughtful conversations, expert insights, and real stories. No matter where you are on your journey, remember, you're never alone, and hope survives.
With a little hope, you can make it through today. With a little faith, someday you'll get through the pain. Just a little love is enough to light the way through your darkest night. Hope survives, a faith in love. Hope survives, a little faith in love. Hope survives.
Hey friends, welcome back to Hope Survives podcast. Today we're having a very important conversation because without a doubt, one of the most common questions that I get asked very frequently is, what is dysautonomia and how does it affect brain injury? It feels like this big word or this big concept that has started to get brought up into the brain injury conversation more and more because more research has been coming out about it, and it's been more apparent that people who've had brain injuries or concussions have dealt with dysautonomia and live with it, myself included. But it can feel like if you don't know anything about it, it can be overwhelming. So today we're here to break it down for you with Dr. Ryan Harvey from the Functional Neurology Center. We have a couple previous episodes on dysautonomia that we will link below that may be able to help you give a more comprehensive look if you want to listen to a number of different perspectives. But I'm very excited to have Dr. Ryan Harvey's voice and to share some of the current treatments and the current landscape of brain injury and how dysautonomia is a piece of the puzzle. For a lot of people, it's the missing piece that makes a big difference moving forward. So before we get into the interview, I'd love to introduce Dr. Ryan Harvey. He is a board-certified chiropractic neurologist and a certified functional medicine practitioner dedicated to empowering patients on their health journey through individually tailored care. He helps those afflicted with post-concussion symptoms, dizziness, TBI, dysautonomia, and many other complex neurological dysfunctions. He received his bachelor's degree from the University of Mississippi in biological science with a minor in chemistry. He then went on to graduate summa cum laude with his doctorate of chiropractic from Life University in Atlanta, Georgia. While at Life University, Dr. Harvey interned at the NeuroLife Institute, their on-campus functional neurology clinic, where he contributed to ongoing research evaluating the effects of applied clinical neuroscience care on self-reported symptoms of depression in adults with medication-resistant depression. Dr. Harvey has studied over 1,000 hours of postgraduate clinical neuroscience and is proud to have completed his core training at the Carrick Institute of Graduate Studies, where he also teaches continuing education courses as a faculty member. He's also completed extensive training in functional medicine at the Karazian Institute, deepening his skill set in addressing numerous metabolic dysfunctions. Dr. Harvey has trained professional athletes from numerous national and international organizations and has been featured as an expert source in Experience Lifetime magazine. Dr. Harvey is now the lead associate clinician at the Functional Neurology Center in Minnetonka, Minnesota. More than a clinician, Dr. Harvey also teaches in various settings, including lecturing on a range of clinical applications to the Functional Neurology Club at Northwestern Health Sciences University. He has a lot of experience, a lot of wisdom, and you may have heard him in some of the spotlights in previous episodes. Today, we're here for a full episode with Dr. Harvey, and we're going to get right into it. So let's talk all things dysautonomia. We would love to thank the Functional Neurology Center for your support of Hope Survives. The FNC offers personalized neuro recovery programs for anyone going through brain injury and a wide range of neurological conditions. When you trust your brain to the team at the Functional Neurology Center, they take the time to get to know the whole you so they can personalize your recovery program for your unique and complex condition. There's hope for a better tomorrow, and the FNC is committed to helping you get back to what matters most. Visit thefnc.com for more. As always, you can stay connected with our programs at hopesurvives.org, our support groups and resources and so many things. And today, we're going to continue talking about brain injury and dysautonomia. I am here with Dr. Harvey from the Functional Neurology Center. Thank you so much for taking the time to have this conversation today.
Absolutely. Thanks for having me. Excited to be here.
We're so excited to have you here on the podcast, and we're going to be talking about dysautonomia, which is something that comes up over and over again. But a lot of people have trouble understanding where it comes from, how it works, things like that. And in my personal brain injury journey, dysautonomia was the missing piece of the puzzle that ended up making a huge, huge difference once I finally got that diagnosis and was able to work on that. So I'm very excited to talk about that. But before we get into the topic, can you just introduce yourself and some of your background and how you got into working with brain injury?
Yeah, absolutely. Yeah, so I'm Dr. Ryan Harvey. I'm the lead associate here at the Functional Neurology Center in Minnetonka, Minnesota. I'm a chiropractic neurologist, a board certified chiropractor, and I also have additional training in functional medicine, brain-based rehabilitation, and I like to kind of blend a multimodal approach with patients like this, right? I think that that's really, really important. I did undergraduate studies at the University of Mississippi and at Ole Miss in biology and chemistry, and kind of got a passion for brain injury, but specifically dysautonomia, because that is something that I dealt with personally as well. And that's kind of how I actually found this work as a patient, and then kind of turned into a provider to help more and more people with these types of injuries and with these types of specific syndromes related to the autonomic nervous system, because I do think it's something that's really underassessed and underdiagnosed, and something that's really kind of missed in a lot of traditional rehabilitation approaches.
I'd love to hear more about your journey from patient to provider, if you don't mind sharing that.
Yeah, absolutely. I grew up in South Mississippi, and I had a couple of concussions throughout the years, really related to my grandparents had a lumber farm. And so I had skull fractures twice as a kid, just working on the farm, right? Having
Wow.
branches hit me, had staples in my head 3 separate times. But, early on, it really wasn't a problem. I maybe had some head pain and had some, but, I felt like I really got over it pretty quickly. And then as I started to get older, I started having fainting episodes. What they later decided were vasovagal syncope episodes. So I started having fainting attacks, probably twice a month, 10 to 12 to 20 times a year. And they were pretty random, and it really didn't really make sense to especially a traditional approach, because, I played soccer, I played high school soccer, and really active kid, and I could do fine doing activities, and then just randomly have a passing out episode when I got really hot or really cold, or maybe I was a little bit dehydrated or overstimulated, and I just start having these fainting episodes. And so, did the full traditional workup, had EKGs done, had EEGs done, had made sure there wasn't anything structurally going on, brain scans, everything looked pretty good. So they're like, you're a healthy kid, it's like, we're not really sure what's happening here. It's kind of like, if you feel like you're going to faint, you should, lay down, kind of thing. Then protect yourself from hitting your head again, because that's kind of like is the progression for those types of things. And I was in my my first year of chiropractic school in Atlanta, Georgia, and I was at a 4th of July party, and I fainted at the party. And so we had a on-campus clinic called the NeuroLife Institute. So they were like, yeah, you should get checked for a concussion. I mean, you hit your head when you fell. And so went and got assessed there, and they were like, yeah, you had a mild concussion here. But then doing some of the autonomic testing, they were able to identify that I had some previous injuries, obviously, that had really put me at a susceptibility for the syncopal episodes. And so that really opened my eyes to, wow, there's a whole nother view to this, and saying, well, there are some controllable things I can do to kind of help put myself in a better spot, right? And so that really kind of opened my mind to all the possibilities in the neurological rehab realm, and like some of the tools that we could use. And it really helped stabilize me as well, in terms of like, I went from, again, 10 to 20 episodes a year. So it wasn't like it was happening every day or every week, but it was really unpredictable. And it really was, obviously a stressor in your life, worried about when is that going to happen? It's embarrassing. It's problematic in general. And so, I've had one episode and since 2019. So I've had one fanny episode. That was a major piece to me finding stability in my life. And it really got me excited to do some of this work and really help people find the resources and find the tools to really work on this stuff, and have a life-changing experience, which is really cool.
Wow. Thank you so much for sharing your personal
Yeah,
journey with that.
absolutely.
That's huge. And I think for our listeners, especially, to understand that you're speaking as a provider, but you're also speaking as someone who's lived it.
Absolutely.
And who, I mean, for me, when I started the podcast and I started helping other people with brain injury, it was like, I so badly wanted people to be able to find help faster, and to be able to find hope, and to be able to find the correct things that are going on, because brain injury itself is not a root cause. The brain injury causes a cascade of things that then can become root causes. So when we talk about dysautonomia, can you just explain from a very basic level, what is it? If someone's listening to this episode, they're like, somebody told me I should look into this, but I have no idea what it is. Can you just lay it out for us?
Yeah, absolutely. So, a big picture definition would be just really general dysfunction in the autonomic nervous system. That can look very different for different people. And I think that's why it's a problematic diagnosis when you come to a lot of traditional providers, right? Because for one person, it could look like syncope episodes or fainting. For other people, it could be lightheadedness or brain fog. Really, the root problem that happens with dysautonomic patients is that there's a problem with blood flow. How does your brain signal around? How do I push blood to different parts of my body and different parts of my brain relative to what I'm doing in my environment? And so I think that's, cerebral perfusion is a major issue, where patients are having issue pushing blood up against gravity to get it to the top parts of your head or to different areas in your brain as you get stimulated. And then, many patients see issues pushing blood away from midline or from your heart, right? So do you have cold hands and cold feet? Do you get abnormally sweaty? How are you doing with temperature regulation? Are you able to push blood to your gut and your visceral organs to repair, but also to digest food? So the hard part with these types of conditions is that one patient might come in complaining of temperature irregulation. One patient might come in with GI dysfunction. One patient might come in with lightheadedness, and they might all have a different version of dysautonomic syndromes, right? And so that's why an in-depth assessment is so important, to help people find out, well, which part of your system is being affected by this, and what type of strategies are really helpful to help you find stability there and find tools to be able to, reduce the frequency, the intensity, and the duration of what you're experiencing.
That's so important. It's so important on how it looks different for different people. And so if someone's like, how do I know if I have dysautonomia? How would you go about helping somebody to understand that?
Yeah. So I think the first thing is just to kind of get a really good general assessment of everything you're dealing with, right? So, a lot of patients will come in and they'll say, well, yeah, I've had cold hands and cold feet my whole life. And that's, it's never really been a problem until I hit my head, right? And so certain people are at a higher risk for developing things like dysautonomic syndrome. You see it a lot with younger females, especially things related to anemias, things related to other deficiencies, but also you're at a higher risk for developing dysautonomic syndromes in certain groups and certain classes of people, right? Other things we like to assess in office are assessing things like someone's tilt table. Do you have normal orthostatic vitals, and do those change how they should relative to change in position or change in activity, right? So that's something from an assessment standpoint, where a lot of patients will be like, well, my main symptoms are generated around fatigue and vision and dizziness. And then when you tell a provider that, a lot of providers kind of don't even think about, well, could this be coming from something more than just the visual system or more than just the vestibular system, which are really commonly impacted areas of head injury, right? but there also is other factors that play into that. What if my visual system's not getting the blood supply it needs, or the oxygen, or the nutrients, or taking away the excess of what happens after you create energy for yourselves? So, really, it's one of those things where we like to assess these types of things with every patient, right? Because we think it's something that's, first off, underdiagnosed and under assessed, and to see, because some patients don't have the classic symptoms or symptomatology related to dysautonomia, but then whenever you get under the hood and you kind of look at things, you can kind of assess that at a higher level and be able to find out, is this a missing piece? And I'd say, in my clinical experience, this is one of the systems that's probably the most common missing piece for patients, where they've been doing a lot of really beneficial things, but if this is missed, then it's always going to be a barrier towards your recovery. In terms of not assessing that and not treating that specifically, is always going to be something that's going to limit the ability of some of the other things you're already working on that should be valuable and maybe are valuable, but they might have limiting returns just based on this ability to be able to push blood around effectively.
So, what's the difference between dysautonomia and POTS?
Yeah, so POTS would really be under that umbrella term of dysautonomia. There's a couple conditions that really fall under that blanket term. Orthostatic hypotension might be one. Vasovagal syncope might be one. Changes in hypovolemia. There's a lot of different terms that people use, and they kind of camp them under this problem with the autonomic nervous system. Even a lot of central pain. If you think about the current literature around fibromyalgia and complex regional pain syndromes, old school term for that was reflex sympathetic dystrophy, which is really another autonomically based condition, right? And so, I think that there's a lot of different conditions that have these types of factors related to them. But again, a lot of people think, oh, well, that's not treatable. There's no treatments for that. Or that's not something that I'm not passing out, so I don't have dysautonomia, right? And I think that those are really misunderstood, dialogues that are in that community of people. And I think more and more people are dealing with this after head injury. That's a really commonly seen one. Post-concussion dysautonomia is really well established in the literature now, but also post-viral, or micronutrient deficiency based, or hypovolemic, or hyperadrenergic. There's all these different camps of things. And finding a provider that's really well versed in this space of dysautonomia is really important, because I think that the average clinician doesn't have the toolbox to kind of work on some of that stuff sometimes.
Yeah, I think there's been a lot of conversation around dysautonomia coming out of COVID.
Mm-hmm. Yeah. That was one of the most common things. And what we saw and what the literature said was that it really liked to affect some of those areas of the brain that were really, prominent in the autonomic system. Some lower areas of your brain stem related to heart rate regulation, breathing regulation, blood pressure, gut function, swallowing abilities, all the things that, when you think about the autonomics, you think about the automatics. What are things that automatically happen without me ever thinking about it, right? My heart automatically beats, my digestion automatically digests, my breathing rate, all of this stuff should be below your level of consciousness. So that's the hard part, is that some people aren't consciously aware of, oh, my breathing rate's changed, my blood pressure's changed, my heart rate's changed, unless you get it assessed, or unless you're really intuitive about those changes in terms of interoception, right? Which is another term related to how well do you know the functions of your body that are below your level of consciousness, right?
Instead of just, for me, for so long, it was, I just feel so off. I feel
Yes.
off. I feel lightheaded. I feel I would say overwhelmed, but the word overwhelmed is such a blanket term. It can
Yeah.
mean so many different things in different contexts to different people. Am I overwhelmed because I'm sensory overwhelmed? Am I overwhelmed because my blood flow is not happening? I did not have the language, nor the tools, nor the understanding to be able to explain or to understand when my blood flow was off. And so one of the things that I experience with it is episodes of low blood pressure.
Mm.
So can you explain a little bit on how maybe that works and what people could look out for?
Yeah. So, that's a really common one. And really what happens is that your brain has mechanisms in terms of how you cross-check information relative to activity, relative to position. A really common thing is positional changes with folks, right? Where I feel the best when I'm laying down, and then I sit up and I feel like problematic, and then I stand up and I feel even more problematic. And then I go and I move my body around, and that's super problematic, right? And you think about, like, how does gravity affect this, right? From a vestibular sense. But then also you have to push blood around very differently when you're laying down versus when you're sitting versus when you're standing versus when you're doing any kind of complex motion, right? And so you have sensors in your body that determine that. You have baroreceptors, which are pressure receptors. You have your blood vessels are constantly opening and closing all day long relative to what you're using. Because you think about, your whole body is not saturated with blood all the time. You're shunting blood around and moving it relative to where you need it. And so what happens classically is when that system becomes problematic, when my brain's perception of where my body is or where gravity is or what I'm using is problematic, and I have problems pushing blood around, like squeezing blood vessels to push blood around or opening blood vessels to push blood around, then you have changes to things like your blood pressure, and you have changes to pushing blood to areas of your brain and of your body relative to what you're doing, right? And so imagine you're going to go stimulate a network of neurons and then you can't shunt blood over there, then that becomes really problematic, right? Because you have to have the oxygen and the nutrients that the blood carries to be able to handle the stimulation. That's part of these overstimulation syndromes. And that's another reason why overstimulation and fatigue both are very, very common symptoms related to dysautonomic presentations.
That's really good. Can you talk a little bit about exercise intolerance as
Yeah.
well and how that could interplay with this?
Absolutely. So for some dysautonomic patients, they're a really good candidate for graded cardio programs and core muscle isometric programs and things like that, which is some of the current literature around treating some of these conditions. Some patients, that's a little bit too much right away, right? You can't start there. It's almost like, I don't want to go have you lifting weights if you have a hard time sitting up in bed or, doing things like that. Or I don't want to go get you on a treadmill if you can't stand up, effectively, right? And so I think meeting a patient where they're at is really, really important from a therapeutic side of things. And trying to find some level of stability is really important to helping the patient be able to do more things in life. Because the goal of rehab in my mind is not like we just treat your brain forever and you're doing brain exercise forever and you're taking supplements forever. We use these tools to help stabilize your system so you can add more things in your life again. And the long-term goal should always be, how do I make my life therapeutic for me again? Because if the grocery store is problematic and riding in the car is problematic and all of these types of things, then you can't use those as therapy, right? But if we can stabilize your system to the point where you can start to do those things in life again, go on walks, go to the grocery store, socialize with family, things like that, that can be therapeutic for you if your system can handle that amount of stimulation. So one of the big goals of, doing a multimodal model of rehabilitation, both through, physical exercise, brain-based exercise, dietary changes, mental health changes, right? Like focusing on all these, facets of health. And that's what it takes with these types of conditions is it's not, there's very uncommon that there's that one silver bullet, that one thing that's just the end all be all. You got to think about all of these things interplay with each other. And how do I put myself in a situation where I can control all these different factors of my lifestyle and my health history to put me in the best situation to be able to see consistent improvements and be able to control all the tangible things, right? And like you said, I think that's one thing that your group does a really good job of is help educate people about there are controllable factors for these kind of things. It's not just I'm at the mercy of what my body's willing to do today, right? And I have no tools and I have no resources. The more you educate yourself and you identify what are the tangible factors I can control, the better you can consistently see improvement in terms of your daily function and then your longevity in terms of what you can add into your life long term.
That's so good. And it's so important to think about how does it actually play out in a daily life?
Mm-hmm.
And how does it actually play out on a day-to-day basis as far as just even people talk about having trouble showering,
Mm-hmm.
right? And standing in the shower for as long as you're able to.
Yep.
And so how would you encourage someone who feels like everything is overwhelming and they're just not quite sure where to start? Are there any simple things that they could do to help regulate their nervous system?
Yeah. So classically safe things for most everyone to be able to do is like you have to control things like your water intake. That's one thing that people think, oh, that's simple, right? I just hydrate. But people don't really understand, like, what does that look like? So I usually tell patients somewhere in the ballpark of, can we try to focus on drinking 50% of your body weight in fluid ounces, right? And so you think that's a lot of water. But what happens with dysautonomia is we think about, we want to make our blood less viscous, meaning less dense, less sludgy, so that it moves through our body more and we have more blood volume, right? That's a problem when you talk about low blood pressure and hypovolemia is this blood volume concept. So really focusing and people say, oh, well, I drink water. And then I say, well, let's measure it out. Let's get a 64-ounce container and I want you to finish that every day, right? Let's just start there. And you can pour from that container so you can measure how much water you're drinking. And people will be like, wow, like I only drank 24 ounces today. And then you say, well, I'm drinking water all day long, but you really don't know how much that really looks like, and really where should it be at relative to where normal would be, right? So that's one factor that's super controllable, and educating yourself about that and understanding how can I build it into my lifestyle and what does that look like for me is really important. Other things that are really helpful are to make sure you're eating enough electrolytes in your diet, right? Through your diet or through supplementation. But the whole thing is that the more solutes you have in your blood, the more you retain water and you don't just, pee it all out or sweat it all out or things like that, right? So the classic management is making sure you're having enough water, making sure you're having electrolytes in your diet. And that's the problem that I've seen is sometimes people take that to the extreme, right? I see patients where it's like, well, my doctor told me I need to put salt in my water, so I'm just eating salt packets. And it's like, okay, there needs to be everything in moderation, right? And obviously you can find one tool that's really helpful and you can kind of go hog wild on that one thing. But again, in moderation, finding these tools and using multiple things at once. Other things that I see to be valuable for a lot of patients is using some kind of compression garments. Sometimes it means compression socks, like things that have a little bit of compression through your body to help that fluid pooling down in your lower body, or like compression shorts, potentially like biker shorts, things like that. Those are great things to kind of help squeeze those blood vessels, whenever your brain's not doing a good job of signaling down to your blood vessels to vasoconstrict, which is something that's really, really commonly affected with dysautonomia patients, right? Also, a lot of autonomic patients, are really having issues with micronutrients. Anemias are super, super common. Micronutrient deficiencies are really, really common. Making sure you're getting caloric dense meals throughout the day, making sure you're controlling all the other controllables, right? What's your sleep look like? What's your diet look like? What's your stress management look like? Most dysautonomic patients are going to see a spike in symptoms whenever they're in a really high stressed environment or they have a lot of stressors in their life. So I mean, sometimes you have control over some of those factors, sometimes you don't, and you need to control the things you can control and put yourself in the best situation to handle the environment that you're in, right? And so I think those are all great ways to start in terms of what are some foundational things that I can start to look at first, and then not only measure that and get a mindset of what that looks like, but then try to do some daily things to make sure I'm promoting, some longevity with those types of resources.
That's really great. Thank you for sharing those
Yeah.
things. And the last question I want to ask here is how would someone be able to know the difference of if they have dysautonomia that could be diagnosed versus a post concussion or post brain injury type of nervous system dysfunction? Is
Mhm.
there a difference and how can they tell the difference?
Yeah, so it's really common that people develop dysautonomias after an injury, right? So after a head injury, things like that. It happened a lot after viral injuries, like COVID was a perfect example of that. And then the literature is starting to come on board with that, where you think about when you hit your head, your brain has a swelling response, what they call the inflammatory cascade of concussion, right? Where those neurons that got hit, they actually develop a swelling almost the same way as had you rolled your ankle, right? But what happens is your brain has a protective covering around it that doesn't really let a lot of stuff in or a lot of stuff out. So swelling in the brain and neurogenic inflammation can really fester for a lot longer than it would in your body, where you roll your ankle and a week later the swelling's gone. Sometimes that doesn't happen the same way in the brain. So that's one issue that we see a lot of with post-concussion syndrome and patients that have dealt with brain injury. But that same mechanism happens with a lot of other factors. If you had a viral illness or a bacterial illness, things like that, you can have those same inflammatory responses happen the same way in a similar very mechanism as if you hit your head, right? And so we look at those and we work on those in a similar mechanism, right? Certain patients are a lot higher risk for that. So like we talked about, very thin individuals with very, very low body mass index, individuals that are women of menstrual age are at a higher risk for that because you're losing, some of your micronutrients and some of your iron, specifically. They're at a higher risk for that. So, I think there's certain groups where I know I'm at a high risk for this. I always had that kind of like, oh, I stood up and I got lightheaded. But then I had that soccer hit, when I was playing soccer and I got shouldered and I shook my head. And then I started to have my hands and feet are getting purple and I have really low exercise intolerance. And, I have a lot of issues with my digestion. I think that that is something that's really, really common for that population of people. And it's really common for head injury, right? So I would say that sometimes it's hard to parse out. And I tell people, is it the chicken or is it the egg, right? Did you have a predisposition to this and your head injury kind of poured gas on that fire? Or did you have a really, really well functioning autonomic system and then your injury created this in circuitry problem? So sometimes I think about it as, well, sometimes it's hard to parse out what's what in terms of chicken or the egg, right? But at the end of the day, we know the factors that you can control to continue to build your resilience back. And there's a lot of people that do see remission in terms of not having daily autonomic symptoms, but again, a lot of it does rely on this ability for you to be able to control all of the controllable factors, to put yourself in the best situation to continue to heal, and then to add your life back. Because that's the long-term goal always, is that once you're back into doing things in your life and they're not provocative for you, then that is where we're at a good spot where life becoming therapy for you, right? Rather than focusing on all of the exercise and all of the other things you've been using as tools to get back to a recovery, rather than using that as a crutch, forever, basically.
That's great. Thank you so much for sharing all of that. So we are getting towards the end of our time here. And the last thing we always ask our podcast guests is, what are your final words of hope for our listeners?
Yes. So, whereas dysautonomia is one of those things that's a kind of a big, scary word, and people don't really feel like they know much about it. These are treatable things. There are lots of tools for people, and there is major hope to see long-term improvements here. And this is not a life sentence of something that I'm going to deal with this forever because I have dysautonomic syndromes. There is absolutely a lot of ground to still gain and a lot of function to still be had. And so continue to do what you can in terms of finding resources for yourself and finding tools to keep building your tolerance, and then let life become therapy for you.
That's great. Thank you so much, Dr. Harvey. And we are so grateful for the Functional Neurology Center as a sponsor of Hope Survives. You can learn more at thefnc.com to get in touch with Dr. Harvey, Dr. Schmo, and their entire team. We can't express enough gratitude and thanks for you sharing your expertise with us today. If you have any further questions, feel free to email hi@hopesurvives.org. We would be happy to pass those along. We're so grateful you tuned into Hope Survives podcast today, and thanks for listening, and we will see you next time. Thanks, Dr. Harvey.
Thank you.
If you enjoyed today's podcast, we would love if you would consider leaving us a rating or a review. We are so grateful to be able to provide this support for the brain injury community. And if you would like to get connected, please visit hopesurvives.org.